It looks like Dr. Thomas hasn't logged in yet. And we have Ramon Bernal logged in.
Hey, Dr. Angelini. It's Alberto Morales. How you doing, sir?
Pretty good. How are you?
Not too bad, not too bad. Dr. Harrison got tied up at the hospital with a patient. He's going to be running a few behind, okay?
Very good, because we have a case that we would like for you to take over on the screen and go over a coronary anomaly that he likes the best. Coronary fistulas.
Okay, I think you have control.
Are we ready to go, or we are waiting for anybody?
Like I said, Dr. Thomas hasn't logged in yet.
Should we wait?
That's up to you if you want to give it a couple more minutes.
Let's do, because if he said that it was coming, it's essential to have a majority quorum.
Okay, great. Then we'll wait a couple minutes for him.
All right. Quorum?
We do.
Hi, Paolo. This is John.
How are you, John? Good to hear it. You survived Paris?
No, I just got out of a case, alcohol septal ablation, so I'm ready to go.
Very good. This is interesting, and I think you will like the questions that we pose. Basically, it's another case of these coronary anomalies in athletes, and the presentation is dramatic, and the questions left are also dramatic and important. So we're going to present this case of a case of a right coronary artery coming from the left sinus of Valsalva. And to introduce the discussion, we can say that it is typical for coronary anomaly, or especially a right coronary artery coming from the left with an intramural course, to become symptomatic. It is not a congenital syndrome that you manifest from early age. It is typical for people that we have collected over the years to express their capacity of becoming, hopefully we can conclude that this is the mechanism, ischemic, with something that happens in their life and in their physical exercise pattern. There may or may not be this is a necessary condition, but for sure we have seen a spectrum of presentations and a spectrum of anatomic presentation forms as described by Ivers. So we'd like to go to the description of an individual case, because we think that it's only by seeing a specific individual case that you will be able eventually to make up your mind and at least to propose new questions. Because what we know for sure from observational studies, typically of the recruits, the million of recruits that were followed over the last several years, 30 years, with an obligatory autopsy in case of sudden cardiac death during the recruits' 2 months of training, is that left cows is the highest risk of coronary anomalies ever seen, and it implies a risk that is much higher than the risk of the right from the left. The left from the right is associated with a 330 times higher risk than a general population. Probably, we are not there yet with definite statements, but probably symptomatic left chaos are about 30% of all the people that are born with left chaos. But only 5% of right chaos will become symptomatic, and most frequently in the adult life.
Paolo, I had a question.
Yes.
You said 330 times as frequent. Is that for sudden death or what?
Yeah, this is the risk of sudden cardiac death.
Sudden death.
During 90% during exercise. Well, we'll go back to that point eventually. But basically, it's a ratio between the carrier and the event of sudden cardiac death based on the new data that we have on how many people in the general population have these anomalies. And for the left from the right is 0.5% or 0.2%. We're not totally sure yet. And then the prevalence of that anomaly in the cases that died, which is 330 times higher than in the others, the ones don't have left accounts. So in general, right accounts has a much lower probability of causing sudden death, especially in the young age and in athletes, and the left chaos is much more dangerous. So this is basically, it's a paper published by Eckerts and Associates in San Antonio, where they followed 23 million American military recruits, and they reported those data. The right chaos was never reported to be associated with sudden cardiac death in recruits. Recruits are special because they are consistent in the age. It's between 18 or 17 and 20 years of age, and is consistent in the amount of exercise they are submitted to, and they are consistent in the fact that all of the victims of sudden cardiac death, especially medical cardiac death, are submitted to obligatory autopsy. The incidence of right chaos was never reported to be associated with death in this population, but some other authors more interested in athletes than recruits, so a more labile denominator and exercise protocol. Basically the Italians, but also the ones from Minneapolis, will tell you that young athletes aged 12 to 35 have in 14% of the cases a coronary death versus 60% of the left accounts in their experience, and 26% in this population up to 35 years of age will be by coronary artery disease. After 35, this becomes the great majority of the sudden death. But obviously, this is early report, small population, basically knowing only the nominator and not the denominator, and especially not knowing exactly how precise is the screening protocol that the different athletes are submitted to before exercising, and this is critical to get comparable data. So let's see what we have. This is a 36-year-old Latin American male living in Texas until he got involved in professional baseball, and he was a professional baseball player for several years with the Reds. So very well trained, very active. I think he was at third base, so a good runner, well trained for that, and totally asymptomatic for a long athletic career. He has now retrospectively a memory of some unusual events like near syncope, but immediately recovered by himself without any episode of sudden cardiac arrest. No arrhythmias described nor monitored, but recently, when he was already retired from sporty work, he decided to start getting back in shape after 2 or 3 years of retirement, and he decided to go to a gym and do especially weightlifting to get a better body shape. And soon he started, and some 3 months ago he started reporting the symptoms, started developing progressive shortness of breath, chest pain, both typical but also at rest, continues for several hours. In the last several days before presentations, he had prolonged episodes. He had to stop training, so a significant limitation. He suffered also a repeated episode of near syncopal spells, both at rest and with exertion. And he described the impression of palpitations now for the first time in his life. A stress test could not be done at presentation because he had such a dramatic and recent onset presentation that Dr. Hernandez, who was supposed to make the presentation today but is in the cath lab, thought that he was in acute coronary syndrome. He was thinking mainly in the spontaneous dissection or something very unusual. Definitely the patient at presentation, at least, but not clearly before, was quite anxious and upset. On his examination, nothing contributory. The blood pressure was 130/80. He was never treated for hypertension. On a Holter recently, he had regular sinus rhythm and no arrhythmias, while he was symptomatic during the recording for near syncope. So strange finding, confusing, but thinking that if this is a cardiac problem, is not a primary arrhythmia, and is more probably in the ischemia territory. So this is the initial EKG and presentation, and the EKG is slightly abnormal, but not definitely so for an athlete. Because of negative T inversion, I would not call this left ventricular hypertrophy. Very low probability by this that this is an athlete's heart, but it could be. Mild cases or recent onset of athletic training can cause this kind of changes. But with that history, obviously the first was to rule out coronary artery disease of some kind, the ischemia at rest. So he was taken the same day of presentation to the cath lab, and we're going to show you the findings. Carlo is mounting a special viewer that hopefully will allow us to see well and quickly the pictures. So these are several pictures in different views of the left coronary artery initially. It looks pretty normal. It's a dominant LAD or large LAD, no coronary disease. Next. It's interesting that eventually when we did the IVUS, there was significant plaquing, not anything critical. In this picture, retrospectively, we have to accept that there is something unusual in the LAD that now could be of importance. As you see, the circumflex is very large and dominant, but the LAD is diffusely narrow after the origin of a diagonal that is fair size. you will see in the next pictures after nitroglycerin that this diffuse narrowing of the LAD actually resolved like it was a baseline spasm. But let's see the pictures. This is already after nitroglycerin. You see that there is a difference in flow velocity, angiographically at least, but especially in size. But it's still a normal anatomy, maybe some spasm at baseline. Next. So looking for the right, Dr. Hernandez found difficulty in identifying the origin. You will see in this selective injection of the right sinus that there is something filling transiently, very minimally here. So there was a right from the aortic root, but not clearly from there. He used the several catheter, and then he called me, and I told him to use my catheter, the one that we designed for a left from the right, because it looked like this was going to be that kind of an anomaly. In the meantime, he did the LV angio. That is very good. It's definitely a normal left ventricle. The ejection fraction is 62%, hypertrophic papillary muscles, but nothing serious. Next. Then an aortic root to confirm that there is nothing from the right sinus of Valsalva. If you look here, there is definitely a right coronary artery that I think it comes very close to the left sinus of left coronary artery that comes from the left sinus of Valsalva. So this is an Amplets one that is getting closer. Next. Is closer, but is not there. But now we know that is from the left sinus of Valsalva and is very close to the anterior commissure that is about here. So this is not the bad injection to make when you're not sure and when you want to describe what is exactly the ostium of the right coronary. The right is about 5 millimeters to the left of the anterior commissure. It's slightly above the left coronary artery that is normal in origin. Next. So now it's the different catheter we have. It's a guiding catheter, and it's an anterior tilt right coronary catheter made for a left from a right coronary artery originating from the opposite sinus of Valsalva. You see at the origin of this coronary artery, there is a suggestion of some stenosis. Could be atherosclerotic, not clearly dissections, but it could be just an anomalous origin with intramural course. Obviously, you need to go to a further level of assurance and imaging to be sure. Next. It is important to do this injection. Next. But it's also important to do the left anterior oblique injection. This is a left anterior oblique 30 degrees where the previously suggestive image of a stenosis of the ostium is now a wider than normal entry, a cone of entry into the right coronary artery. It's a codominant right coronary, but the proximal seems to be larger than normal. So you have a very clear indication that this is probably a compressed coronary artery, larger in one side than normal or the distal, and smaller than the distal in the other projection. So this is where you start rethinking about the cause of the symptoms, and you introduce the probability and not the assurance that this could be the cause of the symptoms, both near syncope, chest pain, shortness of breath, a sizable right coronary artery with a possibly, but we don't know for sure, ostial the proximal section of the right coronary artery. In this picture, you see also again where is the anterior commissure. The surgeons like to know if the ostium and the proximal part of the right coronary artery is above the commissure, because if it is a little lower and crosses the anterior commissure, they will have to detach the commissure and reimplant it after the preferred surgery, which is unroofing. Next. Any questions at this point? This is after more nitroglycerin. Any questions? No.
No.
Nitroglycerin increases the size and increases the velocity of flow, but basically nothing else. Is definitely a sizable right coronary artery that can cause these symptoms. Next. We will show now the IVUS before it was done before this obviously solution of the questions. Can we go to the IVUS now? Well, let's show everything. You will see how severe was the lateral compression of this proximal right coronary artery. This is the process of deploying the stent. We want to position a stent for a significant obstruction of the right from the left in patients with significant symptoms. They have more than 60% stenosis, and we want to start covering the anomaly from a couple of millimeters proximal to where the round cross-sectional area is visible on the IVUS. So it's a very difficult decision where exactly to put the proximal part of the stent. You will see several pictures here looking for the ideal site. If you go inside and with a large artery, like in this case, the balloon tends to push the stent more distally during deployment, you may miss the ostium. Next picture. We are almost there, but as you push the stent or pull the stent, the guiding catheter moves, and so you have this question of where to position both the guiding catheter and the stent before making a final commitment. Next.
Paolo,
Yes.
one of the things that I find useful with IVUS is to identify on IVUS exactly where the ostium is, and then you take a Cine or fluoro image that so that you can correspond that position with where you're going to put the proximal end of your stent.
That's a good observation and comment. We are now, after this case, proposing to start a routine where we take an angiogram at the time of doing IVUS to show exactly where the cross-sectional area becomes interrupted, which is the evidence of tangential origin, slit-like origin of the right coronary artery. So maintaining the same projection and having on a fixed picture that spot, that marker in the control picture will give you a pretty good idea. In general, the easiest way to position the stent is by looking at the distance in the same projection from the opposite side, from the ascending aorta at that level. But it's very difficult, especially because you need to pull the guiding catheter away from the coronary artery selective positioning in order to be able to deploy the stent. And when you pull the guiding, you can pull also the stent. Is pretty tricky. Next. This is a very adequate positioning. It has about 2 millimeters for what we could calculate from the beginning of the slit-like orifice. Next. This is too far in. Next. this is too far in. This is very good. And I think this is where we decided to deliver. Next. This is too far in again, and this is where we decided to deliver. You can decide this point after several testing by the relationship between the first conal branch. You can go back to a couple of pictures. Back another one. You see there is a conal branch, and the distance between that conal branch or infundibular branch and the distal end of the stent will give you the best estimate of where to position the stent. So you want, in this case, to have something like 7 millimeters from the conal branch. Okay, next. This is the delivery. You see now the stent in dry movie, the first few seconds of the angiogram. It seems to be tendentially too proximal, but is very safely deployed, stable, and is definitely in the cone of entry of this coronary ectopic artery. It looks well deployed angiographically, but you need to do an IVUS, and we're going to go to the IVUS next. So this is the pullback from a distal. You see now that the artery is about almost 5 millimeters in size. So it's a large artery. There's the conal branch is around here. There's some coronary disease in the young athlete, very well trained, very concerned about dieting and coronary disease for some reason. But there is definitely coronary plaques. Keep going. There's a movie, I think it's fixed. The previous is there. The next step. But this is the stent. It's coming. Yeah. Okay, we start again the pullback, pre-op. So this is the amount of atherosclerosis in a healthy American diet 32-year-old kid. This was not
very surprising.
No. Evidently the meat is part of the diet. You see there is even calcifications.
Mm-hmm.
Now we see the beginning of the intramural segment where there is an ovalization of the cross-sectional area in systole and diastole, progressive degrees of compression in the transverse diameter. But look at the ostium, and we're going to see it even better. Is this one? At the ostium there is a significant narrowing. Now it's not in automatic pullback, but manual, so you decide where the worst stenosis is manually, by pulling manually. And this is where you can decide the proximal stent should be 2 millimeters of distance from the ostium. This is basically the ostium. So at this level, as you see, this is a new catheter, a Boston Scientific I-Cross, which is significantly smaller than the previous, and is something that I was waiting for with some anxiety, because I found out the majority of our patients who we do IVUS because of symptoms have relatively mild stenosis, and one of the possibilities of explaining that is that the previous cross-sectional diameters of the device, the IVOS device, was bigger than the lumen. This is finally smaller. It's 1 millimeter in place of 1.3 in diameter. So this is 1.8 millimeter in this position. This is also evidence that we are almost in the aorta. This is the lumen, half of the stent, after the IVOS sensor is outside.
Paolo, I'm confused. This doesn't seem to me to be. I think you're already in the aorta. There's dropout at 7 o'clock, I think, from the guide wire. And I'm not sure the other dropout, but I don't see the artery going around the entire oval.
This is the aorta. This is the aortic wall from here to there. And this is the opening of the artery at the slit-like ostium. This is where the cross-sectional area is broken. It's only broken from here to there. It's the beginning of the artery, but there is a part proximal to this where half of the wall of the inside wall of the aorta is open. But this is where we need to be sure to cover, proximal to this side. So this is aorta. This is the coronary artery intramural, the mural or the tunica media of the artery where the coronary artery is positioned is up there. And here is the posterior commissure of the pulmonary artery. The space in this patient, the space between the aorta and pulmonary artery is this black line here. There is no fat tissue, no atherosclerosis at this level. This confirms that atherosclerosis that was very diffuse in this kid is not affecting the intramural portion.
I don't see that. I don't see a ring around the entire artery showing you that you're inside the wall of a coronary artery.
All right. You will see here
layers. I don't think that's the separation between the pulmonary artery and the aorta. That's a three-layer appearance. That black line is the media.
Yeah, but this is what you see. There is some compression of the pulmonary artery by the bulging coronary. So this coronary artery bulges towards the pulmonary. This is the septum, or the space in between the aorta and pulmonary artery at the shorter diameter. In a CAT scan angiography, you see this much better, because you see the pulmonary artery and aorta almost touching at that level. That was the evidence that before was leading to the nomenclature of between aorta and pulmonary artery for this coronary artery. But actually the coronary artery is within the aorta, is within this space, and it may impinge into the pulmonary artery that, having lower pressure, is pushed. And we see in frequent CAT scan angiography, but not necessarily in all, an impingement or a sort of a negative image in the pulmonary wall. Let's see if we can proceed here to show. This is the pullback after deployment of the stent. You see, this is, can you stop it? This is before the ostium, and the artery is totally surrounded by media of the aorta. The media of the aorta normally is about 3 to 4 millimeters in thickness. It becomes bigger than normal in a patient with a large coronary artery. But this is where I think is the shadow of the. Do you think that this is the guide wire artifact?
No, the guide wire artifact is at 2 o'clock.
Around
See
there.
how it shadows out there?
Yeah. But this is the commissure of the pulmonary artery. At this level, there's this space in between pulmonary artery and aorta, I think. So this is the space in between. And we are before passing the anterior commissure of the aorta, the aortic valve. When the coronary artery crosses below the level of the upper commissure, you will see it here. And in this case, you see the pulmonary artery is tendentially a little higher than the aortic valve. And we can, here. You see now systolically there is more compression, pulling back, pulling back. See, this is what I think is a pulmonary artery valve. But this is not with the stent. Huh? The stent is in the next series. This is pre-op. This is again atherosclerosis that you see disappearing at the level of the intramural course, and this is a good chance to review it. Unfortunately, this was copied over and over in the movie, and everything you add, it cannot be disconnected. This is the post-stent deployment. Is well expanded to the size of the artery. This was a 3.5 or 4.0. 3.5 by 18. This is a little bit ovaloid, and we did the post-dilatation after this. But this was the critical evidence. You see that now is a minimal amount of stent. We are still inside the coronary artery, where the roof of the coronary artery is lost. This is aorta. And we can...
I don't think you're in the coronary artery anymore. You're in the aorta already. The stent is sticking out in the aorta, and what happens is, since the artery is not perpendicular to the aorta, you don't see a perfect circle. So you're seeing just one wall of the artery as it comes into the aorta, but the other wall is the aorta.
This aorta, this is lumen of the aorta.
That's lumen of the aorta.
Yeah. This is the proximal part of the stent that is obviously not perpendicular to the probe, but is basically where the ostium is. This is more inside the aorta. You see, this is the aortic wall from here to there that is expanded. This can be enlarged. It's not necessary to expand it for flow. This is a very large opening. But at this point, we are mainly worried about expanding the stent to the size of the more proximal aorta, at this level especially, of the most proximal coronary artery. This is where the ostium of the coronary artery becomes continuous, with the continuous lumen cross-sectional area is complete. More proximal, it's aorta for 50% of this cross-sectional area. More distal is all inside the aorta and well expanded.
Right. There's coronary.
Yeah. This is distal. All right. So now we can go back to the presentation. All right. So as you said, this is the name of the guiding catheter we use that is available to anybody who wants it. I don't have any conflict of interest. I don't never charge anything. They don't have any patent, but is available with this name. During the procedure, we use the run-through guide wire, this new IVOS system, but unfortunately we didn't have the EKG, which is very important to calculate the variation, instantaneous variation of the cross-section with the 30 frames per second is very instructive and important. We have something like 50% of the cases with an EKG signal. I don't know why the manufacturers don't like the EKG. It's so simple to add it, but surely every time they come up with a new system, they eliminate the capacity of having an EKG signal. So we, this is a picture of the eye cross, and this is the size of the catheter, the level of the IVOS probe intravascular ultrasound sensor, 1.01, so basically it was 1 millimeter. So we tried and we succeeded, I think, in this case in deploying the stent from here for a segment is partially only opposed and eventually totally opposed up to the level of exiting the aortic wall. So after the procedure, the patient on the table, obviously after sedation, stated spontaneously without asking anything, it's too early to have any follow-up, but the symptoms were sort of strange. This is not a stenosis that you would consider critical, capable of causing ischemia at rest or prolonged chest pain. But he felt immediately better. He said that he could breathe as good as ever, and that he couldn't breathe that well for 3 months. So we were very encouraged, but obviously we wanted to see more. We put an angioseal and sent him home, and we have an EKG, no? Here. The EKG the day after the procedure is slightly different. Could be, who knows. I don't think we can claim resting ischemia in a situation like this, but this is the EKG. Eventually the patient started developing a sort of a hospital dependence, and he continues to come to the office every single day with chest discomfort, at rest, weakness, palpitations. He was in the emergency room for 3 times. All of the admission were with negative findings. He required, or he was advised, to have an electrophysiology consultation because of some tachycardia, 110 sinus, and he had even a neuro consultation because of some inappropriate behavior of his heart rate. Everything was found to be totally normal, and he's really quite a case of anxiety, and now worse than before. And the question that is presented again is, was this patient sick from the heart, or did he have a casual relationship with the condition of anxiety when he was found to have a right coronary artery from the left?
What about his spasms? Do you have any more documentation of that?
No, no. Now we can talk about what we know from before about when ACAUS manifests in our fairly large experience. Now we have 64 patients that had IVOS for significant symptoms, and only 2 developed progressive symptoms after initial study with IVUS 5 and 10 years after. And with the significant symptoms, we indicated the stent, and the stent was put in the second IVUS when we found minimal changes in cross-sectional area. So objectively, we cannot say that with time the severity of structure increases. But the fact is that the majority of the symptoms were in our patients, obviously we are pre-selecting patients that are above 15 or 16 by age. This patient had a normal active life and presented with these symptoms only at this time. But in our patients, most of the patients were symptomatic from the beginning. Some were only symptomatic from having a diagnosis by screening for these anomalies. But 60% of our initial 62 patients were studied for symptoms, and 34 of these patients required clinically an indication for angioplasty with stent in the presence of a significant more than 60% stenosis. We assume that this stenosis increases with exercise and all sorts of presumptions, but we don't have final and definite proof that this is the mechanism of why they become stenotic and symptomatic. Hypertension, onset of hypertension and diabetes and obesity, but also strenuous exercise, especially weightlifting, can lead to expansion of the aorta, and the project is to do prospective studies on the size of the aorta, specifically at the level of the ostium of the coronary artery. There is an anomaly coming from the opposite sinus and is decreased in stiffness because the aortic wall is sort of separated at that level. But it is still a project in evolution. To recall you the theory of our paper that is now on evaluation by the reviewers for publications, the coronary artery cross-sectional area in systole, which is this, and diastole changes in this case from 2 to 5 square millimeters in cross-sectional area. The short diameter of the artery inside the wall of the aorta decreases in systole and increases in diastole. This is the EKG in this case from which the image was derived. The next. This is the type of animation we came up with to show the mechanism of obstruction with the pulsatility of the aorta during systole. There is not total collapse, but surely this kind of behavior, systolic compression worsens, but it is already there in diastole. To recall, we presented this in our webinars before, but to recall what the objective evidence that this may be the mechanism, and it's good to do it, but we're not there now as to make a general statement. The patients that were treated medically were 23, with stent at 36, stayed pretty much in the same functional class. This is a functional class that implies both the chest pain, shortness of breath, and syncopal symptoms, while the patients that had preoperatively either severe symptoms or moderate symptoms or mild symptoms improved after more than 1 year after an angioplasty with stent, and the majority now are asymptomatic, and 11 or 35% continue to have some chest pain, usually atypical or at rest. All right, and this is for your consideration and comments.
Paulo, that's very interesting. I have a couple of questions. Have you done fractional flow reserve on these patients?
Initially we did, and they were so consistently negative, we have only 3 or 4 cases, that we quit doing it. The severity of obstruction at rest or even with adenosine is not enough as to make it significant in terms of gradient. At the same time, with a vasodilator, you don't really stress the increased stenosis that can occur with an increased load and increased variation in the size of the aorta, which is probably the mechanism of increasing with exercise.
Mm-hmm. But this patient you're saying had symptoms at rest.
Yes.
So if he was ischemic at rest, you would expect FFR to be abnormal.
I would expect normal. Normal with adenosine and normal at baseline, no gradient.
Mm-hmm. Okay, then the other thing that concerns me is the IVUS image. I don't see a wall on the opposite side. I have to, work with you with a picture to actually see what it looks like. But that bothers me because I'm not convinced of what the morphology is that we're looking at or exactly where we are.
Let's replay the. You want to do it with the stent or without stent?
No, without the stent. Before the stent, I want a full pullback with the guide catheter removed backwards. And what you were calling the split, I don't see any difference between, I don't see any wall. I see one wall.
You see, this is
the aorta or coronary artery. I don't see the other wall of what you're saying is the split.
The split, the split ostium.
Slit, S-L-I-T.
S-L-I-T, yeah. You have to recognize that this is a transversal cross-section of the aorta. The split you will see more in an anatomic view from inside or opening surgically, but you don't see the progressive narrowing by this, if not by sequential cross-section. But this is the distal. 1, 2, 3, 4.5 in perfectly or almost perfectly round.
Right. Just run that.
You see here it starts showing there is a segment here that is the distal or more proximal and more distal aortic wall, where this is involved in. Now we're going, look at the plaque. The plaque will gradually disappear. And now when you will see that these 2 diameters change, it's not there yet, you will see that the thickening of atherosclerosis disappear. You see here? Now we are totally inside the wall of the aorta. This is the pulmonary artery to aorta space. See that? And this is the ostium.
Yeah.
In the last portion of this, actually.
So what I'm concerned about is what is that tissue composed of that's in the wall of the aorta facing the aortic side, the lumen side? Because in that one view, I did see more of an an oval or a slit-like appearance, and there does seem to be some tissue.
Here you see?
Yeah, but well, I don't have a pointer to show you.
Do you want to take control of the pictures? You can.
Yeah.
Is Janelle there? Is everybody gone? Eric is there?
I'll get Janelle. Hold on.
It may just be the image quality, and that on your IVUS images, you're able to see it better than what I'm seeing. But
Really?
do you see my arrow at all?
No.
I'm drawing a line from the IVUS catheter down to 7, 8 o'clock.
No. Yeah. We're going to switch and make you the speaker,
Okay.
and you will have control of the table.
You just want him to have control of the mouse?
Pointer.
Yeah.
Yep.
He wants to move the images. And use
Well, I
the-
want to move my pointer so that I can point to you what I'm looking at.
yeah, the mouse.
Okay, if you right-click on Dr. Angelini's name,
Dr. Angelini's name, where are you?
in the attendees section,
Attendee section. Okay, staff, attendees. No, there's no name that appears up on attendees. It's zero.
you're under staff.
Staff.
Staff 3.
Okay, now I've got it.
Right-click on his name, and then ask to request the mouse.
Okay. All right, so now do you see the mouse? I'm not sure.
Yes.
Okay, so you see where the arrow is now?
Perfect.
Okay, it's slow, but there it is.
This is still partially intact aorta,
Okay, so
inside
you're
of the
saying
aorta.
the wall, it's just very unclear on these images from an ultrasound point of view. I see the dropout of blackness behind us. The question is there a wall structure along here, along the radian from the IVUS catheter out to about 7, 8 o'clock?
Yeah, the opening at this level is only at the level of the sensor, the IVUS sensor, is where the catheter emanates into the aorta.
Right over here.
Yeah. But from there down, very closely to where the probe is, it's continuous, is the inner endothelial surface of the aorta.
Yeah. You know what might help is when you are at this level, do an injection of saline and
Right.
try and clear out the blood, which causes this speckling pattern, and then you might see the clearer definition of the wall
Yeah.
of the aorta.
You think that this could be an artifact? This?
No, I don't think it's an artifact, but I don't think it's very clear from an ultrasound perspective that you've actually got wall structure there.
Because this is a contained artery, no? This is a cross-section of an artery with almost complete lining, and this is aorta. So I agree with you that this has an artifact. This is the guide wire, no?
I think so. I can't be sure if the guide wire is at 12 o'clock or at 8 o'clock.
Yeah. And this is the outline of the inner lumen of the artery. This is intima.
I think so, but it's not very clear
Yeah.
on my ultrasound images. It might be much sharper on the images that you're looking at.
It could be. What I
So that's
tell
why
you,
I'm not convinced, and I'm trying to think of ways that you could define that better. One is to clear the blood speckling. with an injection of saline.
Yeah. What I can tell you is that we use saline, and usually it is even better if you put saline with a little bit of blood. And you see the lumen of the artery much better, but not necessarily the aorta. And when you do that injection forcefully, you are in the aorta, so you tend to give the saline to the aortic flow more than the coronary artery, so it's not very helpful. But if you advance the guiding inside, listen what happened. We were a little more inside because we found that finally we could measure a gradient that was quite severe, but it was with a catheter against the wall, the posterior wall of the intramural artery. When the fellow was pulling blood to get an ACT because we were ready to put a stent, the arterial wall was sucked in, and the patient developed severe chest pain. But it was an osteal stenosis aspirated from the back of the artery, of the ostium of the coronary artery. So
right, I understand.
Dangerous to go too far in with a guiding catheter. From outside, it doesn't help very much in showing this, but I assure you that this is the opening, because the next image, and we can look at it again in the previous pullback. You will see that when you come back to the ostium, eventually everything is aorta. This is a side branch. These are probably little arteries. Do you think he sees like this? Yeah, what I see now is that we see much better because it's a projected image. In the monitor, it's not so nice. But now that we go towards the ostium, we are inside the coronary or the aortic wall, you will see that the aortic lumen becomes continuous with the coronary artery.
Yeah.
Now, you see there?
Yeah, I think I've convinced myself that there is something there. It's just not very clear on these images.
Yeah. But we use the intracoronary injection of saline in blood, especially for more distal lesion. For osteal lesion, it's very difficult to have any help. All right. We were told that they are next to accept the paper at interventional from the British Heart Journal. They send the paper to Euro Intervention.
Oh, good.
And Euro Intervention apparently is going to approve it, but is not final yet. They ask more questions.
Good.
Well, keep in touch with you. Very good. Thank you very much. Is Eric there by any chance? No.
Eric, I have another question. Paulo, I have another question.
Yes.
The email that was sent, what did you think about that? The patient with Takotsubo who had a plaque in the right coronary artery.
From New Jersey.
Yes.
Yeah, it's very interesting. Unfortunately, if they don't start doing acetylcholine testing, it's difficult to advance the discourse. It's very important. Both the first and the second cases are very important. I never saw any case of an infarction that eventually was complicated by Takotsubo in the same territory. I saw patients with coronary disease, patients that were treated for severe lesions away from where the Takotsubo was, that were not diagnosed properly, but eventually we show with acetylcholine that it was all a diffuse spasm induced by acetylcholine replicating the clinical presentation of apical dyskinesia. I'm very anxious to see these pictures, and I hope this fellow will get involved in doing acetylcholine test, because the important thing is to be sure that the patient is not a candidate for recurrence of Takotsubo. I don't know of any case in our statistics, or in our experience, that had a permanent damage from Takotsubo with the irreversible damage of the apical portion or other portions that were initially reverted to normal at the end of the initial episode. But there are some reports in the literature of that kind.
My sense of what he was saying was that this is a patient who had both. Had a ruptured plaque and atherosclerosis, inferior MI, and then also had spasm and Takotsubo.
Yeah, I would like to see it. There are several reports in the literature where they claim one or two cases in a large series of segmental Takotsubo. Potentially, there is no reason why, if the interpretation that we give to Takotsubo as a localized spasm, there is no reason why you shouldn't have the possibility of having localized Takotsubo. But the mid-Takotsubo is in the middle of all, circumferentially, all the left ventricle. The apical Takotsubo, it's only at the apex. The very rare cases of proximal inflow Takotsubo, I'm not totally convinced that this is different than the mid-Takotsubo, are essentially symmetrical. Is a circumferential hypokinesia that disappears. So I'm curious to see the original imaging, and we'll go from there.
Okay, well, I'll encourage him to present at the next session.
Very good.
Okay, thank you, Paolo. That was
Thank you very much. Bye-bye.
Bye.
Good night, everybody.